Now, how you are going to do the examination? Remaining parts of neonatal history taking and similar things we have already discussed in a separate section, right? Now, how examination you are going to do in such cases? First of all, you will be doing general examination and noting down the vitals as you do for any neonatal case. Then you will look for any visible deformities in the patient. Now, what are the visible deformities that you will look out for? The visible deformities which have a higher prevalence in a meningomyelocele or neural tube defect patient, they include congenital talipes equinovarus. You will look out for any cleft lip or cleft palate. You will watch out for any visible omphalocele, which is the anterior abdominal wall defect, sac-like structure in which the herniated abdominal contents will be there. You will watch out for any undescended testis in the patient, if it is a male child. So, undescended testis in a male child. It can be unilateral, it can be bilateral. These are the visible deformities which have been described and you must comment upon them. If they are absent, you can simply say no visible deformities. But if any of them is present, you need to mention it. Sometimes when you say, sir, no visible deformity or ma'am, no visible deformity, examiner can stop you and they can ask you, what visible deformities did you look out for? Which are, in other words, they are asking you what visible deformities are commonly associated with a open neural tube defect. And these are the points that you will be mentioning at that moment, right? Then you will watch for posture in the child, what posture the child is taking, right? You will mention upon the posture. Then you will also do the local examination, and whenever you do the local examination, explain the morphology of the lesion. What is the site? Like in this case, it was present in the midline in the thoracolumbar region. Then you will say the approximate size, which was mentioned to you. What is the color of the lesion? Then you will talk about the vertebral level at which it is present. Always mention the vertebral level. Very, very important point. I'm putting a star on this. Is something sometimes we miss during examination. I'm not talking about the spinal level. There are two parts, spinal cord and vertebra. I hope you know that they may not be the same. They are not the same. So vertebral column level, you will mention while describing the lesion, at what vertebral level it is present, right? And any visible tears or rupture is present in the overlying membranes. Any visible tear or rupture in the overlying membrane will be leading to leakage of the CSF. In fact, AIMS protocol says that up to 10% cases of meningomyelocele, they are having rupture or tear by the time they present to a hospital. Then you will look out for whether they are leaky or not. If it is a leaky sac, if the patient is having leaky sac, the sac will be deflated. So it will not be a protuberant sac, it will be a deflated sac. In such patients, transillumination test will not sometimes be positive, right? So if it is already deflated, you will say transillumination test was not done because it was deflated, and this will be having wrinkles on the surface. This is not a good thing to happen. The patient will have high risk of complications and the patient will also have high risk of sepsis. So meningitis can happen in the patient. So you will mention whether it is leaky or not. And then if it is provided it is not completely deflated, you will perform a transillumination test. How to do a transillumination test? This is something in the practical part we have already covered. So transillumination test will show the presence of CSF. If you find some spinal nerves also or remnants also being present, thread-like structures in between, some sac having some opacities present, it can be a meningomyelocele. Coming to neurological examination. Now in neurological examination, first of all, you will comment upon the state of alertness in the child, how alert the child is. Then you will tell about the ability to fixate, whether the child is able to fixate or not. And see, in a newborn, if he is unable to fixate, that can be normally present in a day 1 child also, right? But suppose there is a child presenting in the mid infancy or in the mid or in the 2nd or 3rd month of life, usually the ability to fixate should be present or should be developing in the child. If that is absent, again it will give you a clue something wrong in the brain part also. And you will check for the conjugate eye movements, because esotropia, exotropia, they are often common. In fact, if there is raised intracranial pressure, you can also have the abducens palsy, the 6th nerve palsy, right? Then you will check for the signs of hydrocephalus in the patient. Now the question arises, what are the signs you will look out for when you check for signs of hydrocephalus? First of all, you will take OFC, occipitofrontal circumference, and plot on a chart. Here it had been plotted on a chart and they had said it was between mean and +2 standard deviation, right? So OFC and plot on chart, and if it is above +2 standard deviation, you will say macrocephaly is present. Secondly, you will look out for any suture separation. You will palpate and see for any suture separation. You will see whether the anterior fontanel, what is the status of anterior fontanel? Its size and whether it is bulging or not. Bulging anterior fontanel is a sign of hydrocephalus. Then you will check for any distended scalp veins, and you will also do a fundus examination. On fundus examination, you will check for papilledema in the patient. Right? Papilledema, you will watch out for any sustained raised intracranial pressure in the patient. Then you will look out for any signs of Chiari II malformation. There are 3 signs which suggest a likely Chiari II malformation. If the child is having stridor or intermittent stridor, that is one clue. Second, now stridor child, you will initially think of a airway obstruction, upper airway obstruction, but in a meningomyelocele or a neurological case where you are suspecting a associated Chiari II malformation, stridor in the newborn period can be a clue for underlying Chiari II malformation as well. So stridor can be there, child can have apneic episodes or apnea, and sometimes posturing in the form of opisthotonous posturing can be a sign of Chiari II malformation. So these 3 clues you will also watch out for. We tend to miss out on these signs when we are taking a case. Then always, I've already said, always do a fundus examination and comment on papilledema. So you should be carrying your equipments to do the fundus examination, right? I hope you already know it, how to do it on the bedside. This is something you learn clinically. It cannot be taught virtually. Now moving further, you will also do the neurological examination, which is one of the most important things to do. So first of all, we will do the motor examination, and motor examination will show deficits in the lower limb in a patient of meningomyelocele. So motor examination, first of all, you will look for reflexes. What reflexes you will look for? Suck reflex, swallow reflex, rooting reflex in all, Moro only if feasible. Like if it is a large sac or there is also a cranial malformation, you will not do Moro sac just because somebody has said it. You will do Moro sac, Moro's reflex only if it is feasible in the patient. But suck, swallow and rooting reflex needs to be done in all of these patients. And the most important reflex which must not be missed is ATNR. ATNR stands for asymmetric tonic neck reflex. I hope you remember what is ATNR. In a supine child, turning head to one side, there is extension of the limbs occurring on the same side and flexion of the limbs occurring on the other side. This is what you call as ATNR. Why do you do ATNR? If ATNR is exaggerated or abnormally persisting, or rarely it can reappear, that will indicate high CSF pressure. High CSF pressure or raised intracranial pressure in the patient. So it's a very, very important clue. And for reasons unknown, neural tube defect patients, meningomyelocele patient where there is subtle hydrocephalus, ATNR tends to become exaggerated. So remember this key point. Any child, any newborn, first 6 months of life, ATNR, if it is exaggerated, always rule out that the patient is not having raised intracranial pressure. Right? And if it reappears later, that can also be a clue that there is raised CSF pressure in the child. So ATNR must be done in a NTD case. Examiner will specifically ask you, did you do the ATNR or not? And the moment you say, yes, I did it, so immediately examiner will ask you, why did you do it? How do you do it? And the interpretation. And there, the more answers you give, the more closer you are going to passing not the entire practical, but this case, you are getting the passing numbers. Then motor testing should be done for each spinal level, right? So motor testing you will do for each spinal level, and initially you check for the spontaneous movements, and then you check the induced movements with and without gravity. So how to perform it? It's a neurological thing. That neurological examination, we have covered that point. And you must grade the power in the child by the MRC grading system. Now, interpretation of spinal level involvement. What spinal level is involved, and what is the clinical finding which is telling that spinal level involvement? This is something we need to remember. So let us look at the clinical finding. If the question says, if you examine the child and you find that there is complete bilateral lower limb palsy, lower limbs are completely involved, complete paralysis has happened, you will think of spinal level involvement, which is L3 and above. So L3 and above will show complete bilateral lower limb palsy. In case you find that the child is having flexion of the hips, extension of the knees, but no other limb movements are there, the likely spinal involvement is going to be L4, L5, and L3 will be spared in such patients. In case you examine the child neurologically and you find that the hip and knee movements are normal, dorsiflexion is also normal, but plantar flexion is lost, then S1, S2 is the spinal level involvement and L4, L5 are spared in such a child. If you find that there are normal leg and foot movements, there is along with movements are normal, but bladder and bowel incontinence is there, the bottom is flat, we call it as a flat bottomed appearance, there is absent natal cleft, and there is a patulous anus, there is no tone in the anus, you will think of S3, S4 involvement in the child, and S1 and S2 will be usually spared. When you do motor testing, after motor testing, you must always do sensory testing as well, and it should always be done in a calm, awake child. So if your child is sleeping, you will always wake up the child. There are many maneuvers you can do it. You can gently pick up the child and to and fro rock him gently, or sometimes, just scratching on the anterior fontanel. Gently, it will waken up the child. So always done in a calm and awake child. If it is a crying child, you will wait and let the child get calm, and then you will perform the sensory testing. And we always begin testing via touch and light pinch, and we check for any grimacing, any cry, or any startle in the child, right? So we always start from the lower sacral territory and then proceed upwards. So where do you start initially? First of all, you will be starting from the perianal region. First, check sensations in the perianal region, then check sensations in the buttocks, then check sensations in the legs and thighs, then you check sensations in the pelvic region, and then you check sensations in the abdomen. You check sensations in the abdomen. So this is the way that you are going to proceed when you are checking for sensory testing in such a neural tube defect patient. Now, third thing, the next thing that we need to remember is the bladder and bowel assessment. You will check for any palpable urinary bladder in the suprapubic region. You will check for any dribbling happening on suprapubic pressure. You will check any constant meconium leakage occurring from a patulous anus. You will check for certain reflexes involving the bladder and bowel which have the same spinal cord level involvement. Like in males, you will check for the cremasteric reflex. In females, you will perform the bulbospongiosis reflex. And in both genders, you can perform the anocutaneous reflex. So how to perform these reflexes, again, there is a separate video, detailed neurological examination videos are there. So I'm not discussing them here. So these are the bladder and bowel assessment that you will perform in the patient.